PC-2021-05915, Richard Southwell versus Daniel McKee.
The attorneys have identified themselves now, so if I recall correctly, this is the cross-examination of Dr. McDonald in the middle, so Doctor, come back up.
Having previously been sworn in, please state your name.
Hi, I'm Dr. Jim McDonald.
When you're ready, Mr. Patricia.
Thank you, Ron. Good morning, Dr. McDonald.
Hey, good morning to you.
Doctor, since we were here last week, the governor renewed his executive orders regarding 2186 and 2187, the declaration of emergency and the mask mandate. Is that correct?
Yes.
Ask that this be marked as plaintiff's next.
Plaintiff's Exhibit 42.
I assume there's no objection to the full.
I'm sorry, okay.
No objection to the full, Your Honor.
Without objection, 42 is
Plaintiff's 42 full.
Doctor, first of all, do you recognize the order?
I do?
Were you in any way participant or responsible for recommending to the governor that he extend the order?
I didn't have any specific conversations with the governor about this.
I'm sorry?
I did not have a specific conversation with the governor about this.
Well, did you recommend that the orders be continued to someone?
I did to the team,
To the COVID response team? or-
COVID leadership team.
Leadership team, I'm sorry.
I did, yes.
And I think you testified earlier that it's Dr. Nicole Alexander Scott and Tom McCarthy who would then pass that recommendation along to the governor. Is that correct?
Yes.
And were you the person in that team to recommend this be renewed, or were other people in that team give their opinion about it?
Well, there's a lot of people in the team.
I know we went through who all those people
Yeah,
were. So
but
the
it's-
question is, was it based on your recommendation, or were there other people in the team that also recommended?
Yes, there's other people in the team, there's also other people outside the team.
Okay, well, let's start with in the team. Did you have a meeting of the team where you discussed whether or not to recommend the extension of the mask executive order?
It was briefly mentioned during one of our leadership meetings last week.
It was briefly mentioned.
Yes.
Did you give your opinion to the team in that meeting, that brief mention that you think it should be extended?
Yes.
And you're saying it was just a very, how long was this discussion to extend it?
It's a half-hour meeting, it was just one of many concepts discussed. Nothing's really changed that would have warranted us removing that recommendation, so it didn't require that discussion.
Please, if I may, in your honor,
Go ahead.
move to strike it. Just please respond to my answer.
Okay.
My question,
the answer stands, but go ahead and direct her.
again, doctor, how long a discussion in this leadership team meeting did the discussion about extending the order take place?
I don't remember.
A minute, 5 minutes?
It wasn't long, I don't remember.
Did other people in this team have an opinion that they shared in this meeting about extending the order?
I don't remember. I mean, it really wasn't controversial, so I don't remember any real vigorous conversation about it.
And when you made your recommendation, what were you basing it upon?
The same facts and circumstances we've been discussing throughout the entire trial.
Well, I'm going to ask you to repeat it. What specifically did you rely upon to recommend extending the order?
So Delta is the dominant strain of SARS-CoV-2 in Rhode Island. So that's one factor. Another factor is masks are an effective measure for source control, and masks are effective to some degree to protect people who wear them. Another concept is we have vaccines for people 12 and older, but we don't have vaccines for people who are under 12. We may have vaccines soon. We think maybe early next month, but we don't have vaccines now. Other concepts are our case prevalence, our number of people in hospitals. Our hospitals are still dangerously overcrowded. We still have treatment available. That's another factor that weighs in. Another factor that weighs in, keep reviewing data, keep looking for literature. I went through more literature over the weekend to see if there was any data to support your position, quite frankly, and I didn't find any evidence that supported your position, so I wasn't persuaded to go into a different direction. Other things that factored in is, there's a medical staff at the Department of Health. I don't make these decisions by myself, but I talked to other members of the medical staff, they're all in agreement. We still need the mask mandate in place. We still need the state of emergency in place. So it's not like we're not looking for different opinions. Right now, though, the evidence is very persuasive that we still need to be in the same posture we're in right now.
Doctor, at the very beginning of your testimony, the very first day of this hearing, in direct examination by the state's attorneys, you indicated that there were three things you considered to qualify as a pandemic: hospitals being overrun, no herd immunity, and no treatment. Do you remember testifying to that?
Yes.
All right. So when you say things like masks are effective, can't vaccinate children over 12, under 12, the Delta is prevalent, reviewing data, opinions of medical staff, all of those, none of that has anything to do with those three factors, right?
I don't agree.
Well, which one of those has to do with hospitals being overrun, no treatment, and no herd immunity?
Yeah, I think they're all connected.
Okay. By the way, you also mentioned that other people advised the governor about extending the executive order other than the medical team. Is that right?
I talked about the COVID leadership team. I'm sure the governor has other people outside of the COVID leadership team. I just don't know who those people are.
So there are factors other than medical reasons of why he might have extended the executive order.
I can't speak to things I don't know about.
Well, you mentioned it, Doctor. That's why I'm asking you. You said that there were other people outside the COVID leadership team that were advising the governor on the executive order.
I said I thought there might be. I don't know for sure. I don't know who the governor listens to apart from the COVID leadership team. I'm sure he has other advisors. I'm just assuming he listens to people outside of the Department of Health, but I don't know that for sure.
So let me ask you this, Doctor. What is the metric that you're going to rely upon to end the mask mandate?
Yeah, so it's multifactorial, you know, and I think there's several things we're looking for. The data team is coming up with metrics now. Certainly things that I'm going to be looking for are case prevalence. Like right now, we're at over 100 cases per 7 days, you know, per 100,000. We're at 166 as of yesterday. You know, if we can get below 50 cases per 100,000 per week, that would be really good. I think seeing vaccines available for children 5 to 11 would also be something to be really good. Our hospital metrics improving so that the hospitals are dangerously overcrowded would be helpful as well. Those are some of the things that will weigh into my, you know, thought process. And then we could, you know, conceivably move to masks being recommended and not then required.
Doctor, you keep leaving these things open-ended. You say those are some of the things that would influence your opinion as to when to end the mask mandate. Besides case prevalence, vaccines for under 12-year-olds, and hospitalizations, what other metric are you going to rely on?
You know, it's a pandemic. It's a new disease. It changes. I guess I've learned a little humility before this pandemic, not to be too convinced of anything, and not to back myself into a corner. But, you know, I don't know if there's going to be a new variant. Right now, Delta variant is the dominant variant in the United States. I think it's going to stay that way, but no one can answer for sure. I'm just being honest about limitations of me not knowing the future.
Doctor, there could be a variant, like the Mu variant or the Lambda variant, or they're out there right now, that have no impact on hospitalization or case prevalence. So a variant in and of itself is irrelevant, right, doctor? It's only a variant that causes high cases and high hospitalizations.
Yeah, so I don't think mu is going to be a variant that's going to significantly affect Rhode Island. It hasn't already, so I think we're probably okay with that. Lambda hasn't been an issue either, but I don't know what future variants are going to come down the road. I just don't know. I don't think anybody does.
Doctor, my question is, the variant in and of itself is not the relevant factor to determine whether to continue the mask mandate. It's the variant's impact on case prevalence or hospitalization that's relevant. Isn't that true?
As well as deaths.
As well as this.
Yeah, of course. Yeah, I agree with you.
So those three things, nothing else.
Well, could be something else I haven't thought of here, but
Yeah. By the way, doctor, let's talk about case prevalence. I'm old enough to remember way back at the beginning of this pandemic, we used to talk about things like test positivity rates.
yes.
What is a test positivity rate?
Of the tests you do, what was the percent that have a positive test? In other words, indicating someone was infected with SARS-CoV-2. So if you have 1% of 100, that's a 1% test positivity rate.
And wasn't it at one point a very important metric, if not the most important metric, to determine things like when to allow businesses to open, when to allow people to go back to work, when to get rid of masks?
Yeah,
Right?
early in the pandemic, it had more value to us than it does now.
My question was, doctor, wasn't it one of the most important factors in determining your recommendation, the Department of Health's recommendation for things such as masking, closing businesses, social distancing, all those types of recommendations?
Yes, it was one factor we did rely on, yes.
I can remember, if you tried to travel from another state into Rhode Island, the one factor that determined whether you had a quarantine or not was the test positivity rate from the state you were coming from.
Right,
And if it was over 10, you had a quarantine.
you're right.
And if it was under 10, you didn't have a quarantine.
There were different metrics for different states. Not all of them were 10%, some were 5%, but.
Some of the
yes. Some states used rates as well. Like one of the big problems we had was Massachusetts used a certain number. So the states have their own approaches to this.
So doctor, I had one of my experts, Richard Southwell, go through all of these charts that he gave us. These
Okay.
dashboards, right?
Yes?
And he looked at test positivity rates.
Okay.
And what he found was, with one exception, on August 16th, the test positivity rate was never above 3.8% from June 30th to today.
Right. Yes?
So below even the 5%
Right.
factor.
Yes?
And under the CDC guidelines, that is considered low, a low concern, the lowest concern.
Yeah,
If
so-
it's under 5%, right?
Well, you're interpreting it wrong.
How am I interpreting?
Because different states do different volume of testing. Rhode Island's always been the state that's done the most testing per capita. Since we've always done the most testing per capita, our test positivity rate always is falsely low, so it's not a useful metric for us. So it was useful for us when we weren't doing a lot of testing, but we've always done the most testing per capita for the last 8-9 months. So we don't follow it anymore. It's not useful to us.
So because you test more,
Yes, we do.
and by testing more, you pick up more cases,
Yes, we do.
suddenly the percentage of cases is irrelevant.
That's right.
Wouldn't it be more relevant? I mean,
No.
Doctor, let me ask you this. Of those cases that test positive, are they all symptomatic?
No,
In fact, most of them are asymptomatic.
I don't have the exact number.
Certainly, most of them don't result in a hospitalization,
That's true.
and even a significantly small percentage end up in death.
That's right.
So, it's your testimony that suddenly you're going to ignore the CDC guidelines with regard to test positivity because you just don't think that applies to Rhode Island.
No, actually, you're interpreting it incorrectly. When you look at the CDC's guidance on this, they actually put two different metrics for states to follow. Because the CDC recognizes some states don't do a lot of testing, some states do. Rhode Island chose to follow the number of cases per 100,000 per week because it more accurately reflected the amount of people who were infected in the state could transmit disease. And so we have an idea of how much of our population is susceptible. That's the best approach for Rhode Island.
Okay. On the first page of all of these exhibits, exhibit N, O, P, Q, and Y. These are the dashboard exhibits.
Yes.
On the very first page, at the very top, or just below the very top, there's a chart. It's called Estimated Prevalence of Infection.
Yes.
Right? And I noticed that again on June 30th, the chart was going way down, right?
Yes.
And you thought that was a good trend, yes?
I did.
Yeah. Do you know what the model that was used to develop this projection?
The statisticians and epidemiologists are the ones who proposed the model. I don't have all the variables. I don't know all the variables in the model.
Does the model change?
It's updated to reflect current numbers, but it doesn't change per se. They update based on anything new that happens. For example, if there is a vaccine available, then the model would change. If the masking mitigation is in fact, then that includes that in the model too. So they go by whatever variables are going on at the time.
Doctor, in your affidavit, you wrote at paragraph 28, the modeling team of statisticians and public health professionals at RIDO came to similar conclusions of the Institute for Health Metrics and Evaluation, IHME. Report that based upon statistical analysis, without continued and improved mitigation measures, the Delta variant will cause more than 200 additional deaths by the end of December 2021, correct?
Yes.
This IHME model, is that the model that you use, or the modeling team uses at the Rhode Island Department of Health?
No.
They use a different model.
Yes, they use their own.
Okay. Have they always used their own?
Yes.
So back in April of 2020, when the model was so grossly wrong about the number of hospitalizations, is it still that same model they're using?
It's been updated.
You remember, Doctor, back in April of last year, the model predicted 4,000 hospitalizations, and there were like 300, right?
I do remember that. You know, that was one of the things we used to understand which were the mitigation measures that made the most sense. Governor Raimondo at that time, the director, myself, and a bunch of other people really had to look at the situation of what we had at the time. A new disease, a new pandemic, no way to prevent it, no way to treat it. And we were trying to look at what were the mitigation measures we could do
Doctor,
to decrease that.
Doctor, my question was, the model that was used in April of 2020 was exceedingly grossly wrong. Isn't that true?
I don't know if it was wrong or if it actually prompted us to do the right mitigation measures and they were successful.
Did the modeling team ever tell you, we got it really wrong and we're revamping this model because we got it really wrong?
There's limitations to modeling, so it's updated, the team works on it, and they disclose to us often. It's hard to predict more than 30 days in advance.
Now, what I found interesting, Doctor, was after so Exhibit N is June of 2021, June 29. Then July 7th is a model. July 14th is a model. July 21st is a model. And then on July 27th, it disappears. You see that?
I do.
It says, withheld pending update.
Yes.
Okay? And then it disappears for a while. August 5th, it looks like it got cut off. For some reason, it stops. On July 2021, it's cut off, right?
Yes.
Okay, and then on August 9th, the same thing, it's cut off, right?
Yes.
And then on August 16th, right before the executive order, that's when the scary thing comes out, right? It stops going up, right?
Yes.
August. So, by the way, this model, okay, and then on August 18th, it looks like the same model 2 days later, right?
Yes.
August 24th, the same model.
Yes?
August 26th, the same model, right?
Yes?
Do you know if that model's been published at all since August 25th?
It's on every dashboard. I get the dashboard twice a week. It's on the dashboard every dashboard.
No, Exhibit Q says prevalence model unavailable pending update. That's
Yes?
August 31st.
Yes?
September 7th, missing.
Right?
September 14th, missing.
Okay?
September 21st, missing.
Okay?
September 21, missing. September 28th, missing. Right?
Yes?
October 3rd, missing.
Okay?
October 7th, missing. Or October 5th, missing. And the last date that you gave us, October 12th, missing.
Okay?
And yet somehow, on October 15th, or just before October 15th, you used this model to recommend to the governor to continue the executive order?
It's one of the many things that we use.
Well, you certainly weren't using this to recommend extending the executive
Yes,
order, because it doesn't exist.
Well, it may not be on that dashboard, but I get data updates from people throughout the week. I've seen modeling data throughout the week. I can't explain why it's not on the
Hold
dashboard.
on. Now you're testifying that there's modeling data that you have that you chose not to put in the exhibits that you introduced to this court? Is that what your testimony is?
What I'm saying is, I get many meetings throughout the week. I see modeling data throughout the
I'm
week.
sorry, what I'm saying is I get many,
I get much data throughout the week. I get many reports. I'm not the one responsible for populating the dashboard. So it's likely I have seen models that, for whatever reason, the person who populates the dashboard just didn't populate the dashboard. So I can't explain why one person who works at Department of Health, whose job is to populate the dashboard, didn't get a particular piece of information there.
Okay. Let's talk about the NEDOC score. You spent a lot of time emphasizing how important the NEDOC score was to you in making your decision, right?
Yes?
So Exhibit N, June 30th dashboard. On page 3, hospital list.
Yes?
Okay.
Objection, Your Honor, if I may be heard. If we're going to ask subsequent questions of the doctors, can you at least have a copy of the exhibits beforehand?
Oh, sure.
Thank you.
Well, it's up to the cross-examiner whether or not to use it. I did want to point out for the record that the doctor hasn't had any of the dashboards in front of him, although he's accepted most of it.
Well, that's why don't we do this. Why don't we give that, Sheriff, you can give him exhibits N, all the dashboards, N, O, P,
legislative council,
yep, sorry,
N, O, P,
Q, and Y.
Q, and Y. Handing the sheriff N, O, P, Q, and Y to me.
Doctor, look at page 3 of exhibit N. There's hospital beds and PPE.
Yes, I got it.
Okay, and it says hospital data updated July 1,
Yes?
2021.
Right?
And I noticed MIR, that's the area hospital,
It is.
and it's red, right?
Yes, it
In
is.
fact, it's at 200, it's at the highest number
Right.
of dangerously overcrowded.
Yes.
And the DDOT score measures not hospitalizations per se, but it measures the capacity of an emergency department, correct?
It also includes the number of hospital beds, so it's more than that.
But doctor, the purpose of the NEDOC score is to determine overcrowding of emergency departments, not overcrowding of a hospital in general, correct?
That's not true, because emergency departments are often overcrowded because the hospital's overcrowded. If you can't move the patient from the emergency department to the inpatient ward or the intensive care unit, because those beds are filled, or there isn't staff to man those beds, that affects the emergency department, so they are related.
Doctor, it's the National Emergency Department overcrowding scale. It's not the National Hospital overcrowding scale, correct?
Yes, but
It may measure the number of hospitalization as one, it may measure the number of hospital beds as one of the factors, but the purpose of the score is to determine emergency department overcrowding, period. Nothing else.
I don't agree with you. It's influenced by how many patients are in the hospital. Because, for example, it's not appropriate for patients to be in the emergency department on ventilators. That's a concerning metric. And so it's things like that that are influenced by the rest of the hospital. It's connected. So I draw my inferences based on that. You can interpret it however you choose.
Well, I'm not the only one that interprets it that way, doctor. I have studies, I have reports that have been put out by various groups to talk about whether or not the NEDOC score is even valid. Are you aware of that?
I don't know what studies you have now.
This will be marked as the next plaintiff's exhibit.
Plaintiffs 43 for identification.
Doctor, my guess is you haven't seen this document before.
No, I haven't seen it.
Okay. So you can't comment on the fact that this is a study, an observational study to determine whether or not NEDOCs is useful for detecting emergency room department overcrowding.
I can't comment on this study. I haven't read it before.
Have you ever looked at any literature to determine is NEDOCs a valid score or not a valid score, or what the purpose of the NEDOC score is? Have you ever done any research into what NEDOCs is?
I've talked to subject matter experts in the state of Rhode Island and our state government. I've talked to the stakeholders who use it. I've talked to the emergency department physicians. So I understand how we use it and what it means to them. I've gotten local guidance on this.
Again, this be marked as the next plaintiff's exhibit.
Plaintiffs exhibit 44 for ID.
Doctor, this is an article from the American Journal of Emergency Medicine. Have you ever heard of that journal?
Yes?
It's a reputable journal?
Yes.
Okay. So, this study that was done in that journal, I'd ask that it be moved to the full exhibit.
Objection, Your Honor. Your Honor, the doctor's already testified that he doesn't have an opportunity to review that exhibit under the hearsay rule. They are the team that should be admitted in full because it hasn't been relied on that doctor. And if the doctor's provided any testimony with respect to that exhibit, he needs to be given a full and fair opportunity to review that exhibit so he can formulate a coherent opinion. The opposing counsel is trying to get that in for the truth of the matter asserted therein, and therefore the doctor needs an opportunity to review that. It's not solely for impeachment purposes that he's trying to get it in full.
It stays for identification at this point.
Thank you. Doctor, the headline of this article is the inaccuracy of determining overcrowding status by using the National ED Overcrowding Study Tool, otherwise known as NEDOCs, right?
Yes, you read the title accurately.
So, if I told you in this report, what the researchers found was that DDoS was seriously overestimating the overcrowding.
Again, no objection. He's providing a summary of what
Can I finish my question first?
First, you should be allowed to finish the question. Secondly, you can pose a hypothetical to an expert,
Thank you.
assuming that these facts are all appropriate.
So again, doctor, if I told you in this report that the researchers found that the EDOT score was overestimating the overcrowding problem, and that they compared it to actual interviews of emergency department staff who didn't think they had an overcrowding problem. Would that influence your opinion in any way as to the legitimacy of the EDOT score?
Objection form calls for a compound question, and I rely upon my prior objections noting that the doctor has not read the study. He is a lay witness, opposing counsel is trying to summarize a study that the doctor has not read, and he does not have expertise in the field of medical science.
Hypothetically.
Sustained. It's not covering.
Hypothetically speaking, though, if this report said that the DDoT score is overestimating overcrowding in emergency departments, would you want to consider that part of your opinion as to whether the DDoT score is a valid score?
Objection, Your Honor. Dr. McDonald is an expert witness in this field. He's trying to rely on a document that the doctor has not read to cause the doctor to speculate. The doctor is here to provide an expert opinion, not to do speculation with respect to that.
Excuse me. Repeat the question.
I'm sorry.
Question. Hypothetically speaking, doctor, if his report said that the EDOT score was overestimating overcrowding in emergency departments, would you want to consider that as part of your opinion as to whether the EDOT score is a valid score?
Overruled, you may answer.
You know, I would look at any study. You know, quite frankly, I don't know what year this study was done, but I'd look at any study, give it the weight, you know what I mean? And I corroborate with what I know based on what's in front of me, plus what I'm hearing from the local emergency physicians and the chief medical officers and CEOs. So I'd look at any study.
Yeah, that's sure.
The court is relying on Rule 703.
Thank you. Now get back to exhibit N, page 3, Merriam score of 200. If you look at just the percentage of emergency department beds that are occupied as opposed to available for operational beds, it looks like 36 beds are occupied and 73 out of 73 operational beds.
Yes, that's right.
Less than half of the beds in the emergency department are occupied.
Yes, you're right.
And yet somehow, Merriam Hospital's emergency department was considered dangerously overcrowded, even though half of their beds were vacant.
Right, it was.
Okay. And the ICU beds, which you said was an important factor too.
Yes.
Again, only half of the ICU beds were occupied.
Yes, you're right.
And the total non-ICU beds, 229 out of 259, about 85%.
Yes, yes.
So how did Marion Hospital on June 30th be considered dangerously overcrowded when half of their emergency department beds are unoccupied and half of their ICU beds are unoccupied?
Yeah, so you're getting on one of, I think, the critical parts of this gross misunderstanding of the pandemic. Just because there's a licensed bed in a hospital doesn't mean there's staff to take care of the person in the bed. And quite frankly, it's not the only metric here that's used here. In other words, one of the things I keep hearing from doctors who work in the emergency room is, we don't have nurses, we can't get nurses. And I hear this from the hospital executives as well. We can't get staff, there just isn't staff. So the staffing shortage has been a significant factor.
The staffing shortage that's being exacerbated by the vaccine mandate that you put up, right?
Objection, Your Honor.
Fair question, Your Honor.
It's not a fair question to consider the percentage of the population that's at issue is less than 1%.
Well, one we see what the document is. Overruled.
So this is such,
Overruled.
I'm sorry, go ahead. If you could read back the question, please.
Is that because of the vaccine shortage?
Yeah, so
I'm sorry.
I have the question in my head, but I'm not.
Okay, but if you don't need the question, go ahead.
I can do it, yeah. So, the vaccine mandate has moved us from 77% of healthcare workers fully vaccinated to 95% of healthcare workers fully vaccinated. That 5% shortage that we have now isn't just in hospitals. And I don't know off the top of my head how many of that 5% are working remotely. One of the exceptions in the regulation for people to be vaccinated is people working remotely. There's a lot of people who work full-time remotely. Radiologists, pathologists, there's some other healthcare providers who work fully remotely. So I don't remember how much of that actually is. So we've had a shortage before the vaccine mandate, and there's still a shortage now. There's just a shortage of a lot of things in the United States right now, including staff.
All right. Doctor, if you look under the score definition that's on the upper left-hand part, there's 7 factors.
Yes?
Which of those 7 factors says the amount of staff?
There's none that refer to staff. They're all metrics that infer the ability of a hospital to move patients through the emergency department.
So, doctor, when you testify that you're concerned about the hospitalization overcrowding, you were really talking about the emergency department overcrowding, not the normal hospitalization beds, correct?
It's both, because even though there's a bed in the hospital, if there's not a staff member to take care of it, it's not a bed we can actually put somebody in. And that's why it's concerning, and that's why the number of people in the hospital influences how that's going to be effective in the emergency department. And this is part of why I corroborate information with people I know in the industry to say, gee, does this make sense?
All right, well, you'll notice on the bottom of this chart of 10 or so hospitals, there's a total number listed, correct?
Yes,
And so total hospital beds, 2,257.
right.
Okay. Does that number appear consistently through all of the exhibits that we have?
It's my understanding.
Okay, well, let's go to July 21st, which is exhibit O. We'll tab July 21st. And then third page after that. See that?
Yes, I'm there. I'm at the July 21st, page 3.
The number still appears there, right?
Yes, it says 2,257. I mean, it may change, but it looks like it's the same there.
Now let's go ahead to go ahead to exhibit Q, which is September. Okay. Now, September 2nd, on page 3, there's no info. It says pending update, right?
That's what it says.
Let's go to September 19th. Again, the third page in.
Sorry, I don't have one for September 19th.
I'm sorry, September 9th.
September 9th?
Yeah, 9/9. Again, withheld pending review, correct? Page 3.
That's what it says.
Let's go to November, September 16th. Third page in. What's the total?
I don't see a total at the bottom.
Isn't it true that after September 16th, the dashboard stopped reporting how many total beds there were?
It may have, I don't look that close, I didn't see that detail, so I don't know.
And if I told you that, again, using my crack statistician plaintiff, he ended up calculating what the total number of beds is. And it's around 1,800. It's about 400 beds less than previously reported.
Okay, that's your testimony,
It's not my testimony, doctor, it's the data. Are you aware that between July and September, 400 out of 2,200 hospital beds in Rhode Island just disappeared?
Objection, Your Honor, it's only referencing one date, which is the 19th. The doctor should have an opportunity to go through all of the exhibits. It's going to ask for a question covering 2 months.
I asked between July and September, and that's what I'm doing. I can get it, but I'm asking between July and September.
Same objection, you're still covering a 2-month time span. The doctor should have an opportunity to review it and want to answer.
Well, he's got the law in front of him, right? Doesn't he have those records in front of him?
Yes, it does.
So, of course he has time to answer a question.
I don't know who is responsible for putting this sum of all the numbers down there. I don't know a lot of the people who actually populate the dashboard by name. I know of them who work for us, but I can't say that there's some reason why it doesn't appear there. Now, I don't know the answer to your question, why there's 400 less beds. What I do know is we don't have the staff to run the beds we have. That's what I know.
So again, hypothetically speaking, doctor, if you look at this data and it showed that 400 hospital beds, nearly 20% hospital beds in Rhode Island suddenly disappeared between July and September, would that influence your opinion about your recommendations regarding the emergency order and the mask?
No, it wouldn't.
You wouldn't be curious as to where these 400 hospital beds went?
You know, there's usually a logical explanation for a lot of things, so I'd ask around the department, and I can do that later on today if you'd like. But quite frankly, when you look at the actual scores, what I'm hearing from physicians who work in various departments and hospital leadership, it's compelling to me that the hospital is stressed and overcrowded. I can even testify to my own experience. If I try and go to a hospital, they're really overcrowded.
Well, that's not unique to emergency departments, doctor. I can tell you how many times I've been to an emergency room and it's been overcrowded years ago. That's a persistent problem in this country. Emergency rooms are always overcrowded. Ask anybody in this room. So you want to use your personal experience about going to an emergency room and it's overcrowded and use that as a basis for an emergency audit? Is that what your testimony is, doctor?
Objection, Your Honor, that's not what he's saying. He's mischaracterizing the evidence. And he's to ask questions, not provide factual basis on everyone in this room regarding emergency rooms.
Rule the doctor can answer.
Yeah, so obviously that's not what I said. What I said was, I looked at the NEDAC score. What I said was, I've talked to the emergency department physicians in the state. What I said was, I've talked to chief medical officers, chief executive officers of the state. I have a good feel for what goes on in the state. So yeah, I'm very confident the hospitals are indeed overcrowded. And no, I don't accept the premise that hospitals have always been overcrowded. We're in a pandemic. It's unlike anything this country's ever seen before. It's a very unique time in our history. So I'm very confident in saying, when I hear doctors and nurses tell me that they're stressed, that they're overworked, that they're burnt out, and that they can't get staff to work, that they're right, and they're telling me the truth.
Doctor, you did testify earlier that you had a conference call with a bunch of hospital CEOs
Yes.
right before the executive order was issued back in
Yes.
August. Was Care New England Hospital one of those hospitals, CEOs or CFOs that you talked to?
It was August 12th, and yes,
Okay. And here in New England runs what hospitals in Rhode Island?
they run Butler, they run Kent, and they run Women and Infants. Those are their main hospitals.
So, Doctor, when you had this conference call with, she included the CEO from here in New England, did they tell you that on August 25th, they were going to do a quarterly investment call with their investors, their bondholders at the hospital, in which they were going to present that they're desperate to bring patients back to return to pre-COVID levels? That in fact, they were being underutilized as a hospital, and that they were hoping to bring patients back. Did he tell you that? Or she, whoever the CEO was?
So it was Dr. James Finale, and it was Dr. Hari Gopal-Krishna. They did not mention anything about an August 25th investor call.
Should I have this marked?
Plaintiffs 45, marked for identification.
Doctor, if I present it to you, well, first, take a moment to look at this document.
Yes, so how can I help you with this?
You could go to the 11th page in.
Objection, Your Honor, this is not a full exhibit, it should be referred at this point.
Make it better.
You guys have been asked to read it.
And as a result, since it has been moved to full, it should be referred from. The doctor already said that he was unaware of the phone call.
He hasn't been asked to read it. He's not reading it. The 11th, page 11.
This key utilization statistics, 9 months ending June 30th. If I told you, doctor, that between 2018 and 2020, that the emergency room visits at here in New England hospitals went down from 70,000 to 58,000 visits. And that in 2021, it went down even further to 56,000. Would that be important for you to know as to whether or not the emergency department is being overwhelmed in Rhode Island when hypothetically 20% fewer visits are happening during COVID pandemic than were happening before?
So I'm open to all information. I really do like to hear about everything. I know during the early part of the pandemic, emergency departments were very uncrowded. Like from April, May, and June of 2020, there were a lot of people going to anywhere, including emergency departments or even doctor's offices. So I'm open to any information. So if there was any information, and I actually do that. I'm actually always looking for different information. I'm not trying to push one particular point of view. I just try to keep my mind open to whatever's out there.
Well, it's good to know. It's good to know. So if you go to page 14, where it says multi-pronged response. And again, I told you that the CEO of Care New England was telling his investors on August 15th that they wanted to bring patients back to return to pre-COVID levels. Would that be important for you to know in making your determination as to whether to extend this emergency?
Objection, hearsay, hypothetical, doctor can't authenticate this document.
This hypothetical. I think the doctor just testified that he welcomes this new information.
Doctor, is that information of a type reasonably and customarily relied upon an expert in your field? Informing opinion?
No, it wouldn't be something I would rely on.
Okay, Doctor, let me ask you this. The chief executive officer of a hospital tells you on August 12th that his hospital is severely overcrowded, correct?
Yes,
Hypothetically, you find out after August 12th that the same CEO was telling investors that his hospital is undercrowded.
I don't see that in this
Doctor,
document.
hypothetically, if that were true, would that be important for you to know?
I wasn't on this call. If it was true, I'd love to know, but I have no reason to doubt the honesty of Dr. Finale. He's been someone who's been an honest broker with me every time I've dealt with him.
So would you go back and ask him about this and say, hey, doctor, did you really tell investors on August 25th that you're underutilized? Will you do that for us, doctor?
Objection, Your Honor.
Sustained.
Noticed another change in the hospitalization chart on the dashboards. Again, you go back to Exhibit 10. On page 3, hospital beds. The captions are total hospital operational beds, non-ICU operational beds, non-ICU occupied beds, ICU operational beds, ICU occupied beds, emergency department operational beds, emergency department occupied, correct?
I see that, yes.
Now I'm going to ask you to go to Exhibit Q. And the date is, again, September 16th. The third page in. You notice something changed in that caption?
I don't.
See where it says ICU staff capacity?
Yes,
That doesn't appear in June dashboard, right?
it doesn't apparently.
So they suddenly added a category at some point in September, is that what happened to the dashboard?
Yes, I'm not the one who constructs the dashboard, so I assume that's what happened.
So before September, staffing wasn't an issue, but in September, staffing became an issue.
I wouldn't draw that inference,
Well, why else would you have it listed on your very important dashboard?
because documents are often updated throughout the pandemic. It's a new disease, it's a pandemic, it's a response. The whole pandemic response from the Department of Health has been constantly improving our response. So my guess is someone just decided to add a metric there that they thought would be helpful.
Somebody, okay. But adding that metric, would that have changed the way the score was calculated?
No, it's not a variable in the 7 elements that are there.
I'm sorry, it's not a variable and
It's not a variable in the 7 elements that are listed in the upper left-hand corner.
Then why put it in the chart?
Because I think people find it informative and it reflects what their staffing capacity is.
So the fact of the matter is, doctor, these charts, these hospital detail charts, going back from June until today, the metrics that actually go into them keep changing. The total number of beds keeps changing. The issue of whether they're staffed or not is changing. And even the fact that in June you have NEDOC scores saying it's dangerously overcrowded if an emergency room is half occupied. This keeps changing through all of these documents.
I'm sorry, is there a question?
Isn't it true it keeps changing?
They're updated. Yes, of course they're updated.
And yet, somehow, we're supposed to rely upon this inconsistency to determine whether or not hospitalizations, overcrowding is a problem in Rhode Island.
Yes, I rely on this as one of the many things I look at Like I said, I've talked to hospital leadership, I talked to emergency room physicians and nurses. I use a lot of things to help make recommendations. I don't just rely on one document, but I think this document is reliable. I think it's persuasive, and I think it's accurate, and I know the healthcare providers who report it count on it.
Let's look at the 14-day projected hospitalizations. And go to exhibit 10. Excuse me just a moment. We're going to the second page of 10. It says hospitalizations, and I think there's a chart here on top, correct?
Yes?
And part of the chart includes projected COVID hospitalizations, correct?
Yes?
Now, I want you to go to exhibit Q. Second page.
Right.
Exhibit Q, the second page, which would be hospitalization, it says COVID data through August 31st, projections updated August 19th. Correct?
I have exhibit Q, and I'm on the second page.
Do you see the projections updated August 19th? In the box on the top.
Yes, I do.
And then it says 14-day median projected COVID hospitalization occupancy. COVID hospitalization projections under development.
Yes.
In fact, after this date, through exhibit Q, which is September, and exhibit Y, which is October, there is no more 14-day COVID hospitalization projection. Isn't that true?
Yes.
So you have data that you rely on, projected COVID hospitalization, you would agree is an important metric, right, doctor?
Yeah.
And yet you have no data after August, the end of August, as to what those projections are.
Yeah, there were updates.
Again, let's go back to exhibit N, the first page.
Okay, I have a lot of exhibits up here. Do we need all of them? Can I clear up some of this?
You can put them in a little stack to the side if you like, doctor.
Well, I'm just curious, do you just need 42 and do you need the quarterly investment column?
Do you want to keep just the dashboards for a few minutes?
Yeah, that would be fine.
It's just easier if I know what we're doing here.
That's fine.